Welcome to the deep dive. We're here to take a pile of complex information and really distill it down for you.
Make it digestible.
Exactly. So today we're stepping right into the OR, focusing on that critical moment. Emergence from anesthesia. And there's this, well, persistent problems. It's kind of lingered, hasn't it? Residual neuromuscular blockade, RNMB.
Yeah, it's a big one. Often subtle, you might not even pick it up easily without monitoring.
Right. But it impacts, what, up to 60% of patients in the PACU?
That's the figure, yeah. And it's not trivial. We're talking serious risks, airway obstruction, pulmonary complications.
Unplanned ICU admissions, even.
Absolutely. Things like weakness in the supralaryngeal muscles that can block the airway, mess with swallowing, increase aspiration risks.
Serious stuff. And, largely preventable.
Preventable, that's the key word.
But then along came this, well, genuine game changer. Sugammadex.
Ah, yes. Brilliant.
It's really revolutionized how we approach NMB reversal, hasn't it? Offering, a new level of precision and speed.
Totally different ballgame compared to the traditional methods.
So our mission today is to really unpack this drug. We'll look at its remarkable efficacy, but also dig into the potential risks, the nuances.
And the economics, too. Can't forget that.
Definitely. The market dynamics. The goal is for you, listening, to walk away truly well-informed with practical insights.
Ready to dive in.
Let's do it. So this molecular marvel, what actually is Sugammadex?
Okay, so at its core, it's a modified gamma-cyclodextrin. Now, picture this. Think of it like a tiny cone-shaped donut.
A donut. Okay, I'm with you.
Yeah, but a special donut. The outside surface is hydrophilic, water-loving, but the inner cavity, that's lipophilic, fat-loving.
Okay, so that structure must be important.
It's everything. That specific design lets it perfectly fit around and basically trap or encapsulate certain larger molecules.
Like a molecular catcher's mitt.
That's a great analogy. It forms this really tight one-to-one complex, non-covalently, mind you, with specific NMBAs.
Primarily the aminosteroids, right? Rocuronium, vecuronium.
Exactly. Rocuronium, it binds with about 95% efficiency. Vecuronium, around 90%. Pancuronium too, but less so, maybe 61%.
And crucially, not things like suxamethonium or atracurium.
Correct. It does not bind succinylcholine, atracurium, or myvecurium. It's incredibly selective.
So how does that catching actually reverse the blockade?
Well, it's kind of a two-pronged attack. First, it just floats around in the plasma and grabs any free NMBA molecules, making them inactive. Simple enough.
Okay.
But second, and this is really clever, by removing the free drug from the plasma, it creates this steep concentration gradient between the plasma and the neuromuscular junction.
So it pulls the blocker off the receptor.
Precisely. It literally pulls the NMBA molecules away from the junction back into the plasma, where snap they get encapsulated to.
And that rapid removal means fast recovery.
Super fast recovery of neuromuscular activity.
Which is just fundamentally different from, say, neostigmine.
Oh, completely different world. That's the key differentiator. Neostigmine works by inhibiting acetylcholinesterase, right? Increasing acetylcholine at the junction.
Right, leading to all those potential cholinergic side effects, bradycardia, secretions.
Exactly. Sugammadex doesn't touch the cholinesterase system at all. So you bypass all those side effects. No bradycardia worries, no hypotension, no bronchoconstriction from the reversal itself.
And therefore, no need for glycopyrrolate co-administration.
Correct. Fewer drugs, cleaner reversal.
How stable is that Sugammadex NMBA complex once it forms? Does it, fall apart?
Practically speaking, no. It's incredibly stable. The Sugammadex rocuronium complex, for instance, the association constant is astronomical. The ratio of complexes formed to those that dissociate is something like 25 million to 1.
Wow. So once it's bound, it's bound.
Pretty much. For all clinical purposes, consider it fixed.
Okay. And pharmacokinetics, how does the body handle it?
It's pretty straightforward, actually. Linear, dose-dependent kinetics. The main thing to know is it's almost entirely eliminated unchanged by the kidneys.
Really? So it just takes the rocuronium with it?
Yep. Over 90% is gone via the kidneys within 24 hours. It effectively switches ROC's elimination pathway from mainly biliary to mainly renal.
And its half-life?
About 1.8 hours in healthy adults. So relatively short, very clean profile, pharmacokinetically speaking.
Okay, so that's the how. Let's get into the why.
Yeah.
Why has this drug had such a huge clinical impact? What are we seeing?
Well, the biggest thing is just unparalleled speed and predictability. Let's take routine reversal, okay? TOF, count of 2 or more.
Yep. Standard scenario.
With 2 millikilograms of Sugammadex, you'll typically get a TOF ratio over Bornene in about 2 minutes.
2 minutes.
Yeah.
Compared to neostigmine, which is...
Usually around 17 minutes on average, maybe longer.
That's a massive difference in the OR.
Yeah.
Huge.
It is. And think about deeper blocks, say moderate blockade, PTC of 1 or 2.
Right, where neostigmine struggles or just won't work reliably.
Exactly. With 4 millikilograms of Sugammadex, you're looking at reversal in roughly 3 minutes.
Wow. And what about profound block, like rescue situations?
That's where it's truly amazing. Immediate reversal of a profound block, let's say 3 to 5 minutes after an intubating dose of rock. 16 millikilograms of Sugammadex.
And the time?
About 1.5 minutes. Astonishing. That's faster than waiting for spontaneous recovery from succinylcholine.
Incredible. So that speed must translate into better patient outcomes, right? Particularly thinking about PPC's postoperative pulmonary complications.
Absolutely. Critical advantage there. The stronger trial, big multi-center study showed it quite clearly.
What did it find?
Sugammadex significantly decreased PPCs, things like pneumonia, respiratory failure, pneumothorax in non-cardiac surgery patients. The rate was 3.5% with Sugammadex versus 4.8% with neostigmine.
So that reduction in residual blockade really matters for breathing.
Directly translates to better respiratory outcomes. Fewer weak airways, less aspiration risk, better cough. It all adds up.
And beyond just avoiding the bad stuff, how does it help the process? Surgery itself? Recovery?
Well, being able to reverse deep block quickly, that improves surgical conditions, especially for lap cases. Surgeons love it.
Better visualization, less movement.
Exactly. And then post-operatively, we see benefits across the board. Less pain reported in some studies, like lumbar spine surgery, fewer complications in bariatric surgery, better quality of recovery after eye surgery.
And readmissions. Discharge times.
Lower incidence of unplanned 30-day readmissions and fewer delayed discharges. It streamlines the whole perioperative journey.
Seems like it really broadens the scope of where we can confidently use NMBs. What about those tricky situations? Difficult airways? Cardiac patients?
Good questions. For difficult airways, look, it's not a magic bullet, right? But in a can't intubate, can't ventilate scenario after giving rocuronium, having that rapid reversal option with 16 millikilograms, it can be a crucial rescue tool.
A potential lifeline.
Potentially, yes. And cardiac safety is a big plus. Unlike neostigmine, it has minimal to no effect on QTC prolongation.
So better for patients with things like Brugada syndrome.
Ideal for them, really.
Right.
Where QTC issues are a major concern.
What about patients with complex histories? Neuromuscular diseases.
It's a huge advantage there, too. Think Duchenne muscular dystrophy, ALS, myasthenia gravis, or even ECT patients.
Right, where reversal needs to be fast and reliable.
Sugammadex provides that. Faster return of spontaneous ventilation in these often very vulnerable groups. Also great for cases needing intraoperative neuromonitoring.
Like thyroid or facial nerve surgery.
Exactly. You need precise control and then rapid reversal when the monitoring is done. Sugammadex allows that flexibility.
And it lets us potentially avoid succinylcholine for RSI sometimes.
That's another big one. You get rapid onset with high-dose rock, and then you have a rapid reversal agent if needed, avoiding all the potential sepsis side effects, hyperkalemia, myalgia, MH trigger.
Cleaner profile for rapid sequence induction in many cases.
Offers a really valuable alternative, yeah.
Okay, so it sounds amazing, but not this perfect. Let's talk about the nuances, the risks, side effects. What do we need to watch out for?
Right. Important discussion. Generally, it's well tolerated. You might get some common, usually mild things. A weird metallic taste, maybe headache, fatigue, nausea.
Dysgeusia, right. Usually transient.
Yeah, typically mild and self-limiting. But we do need to be vigilant about more serious adverse events.
Like hypersensitivity. Anaphylaxis.
Exactly. It's rare, but it can be severe. Cardiovascular collapse has been reported. It's definitely considered an emerging trigger for perioperative anaphylaxis.
How quickly does that usually happen?
Most cases are within about 5 minutes of administration, so immediate vigilance is key. Diagnosis involves, tryptase levels, skin tests later, maybe specific IgE tests.
And there's this weird twist, isn't there? Some debate about whether it's the Sugammadex itself or the Sugammadex rock complex causing it.
Yeah, that's an intriguing area. Some studies suggest the complex might be the culprit, not just the free drug. Still being investigated.
Which leads to that dilemma. Can you use Sugammadex to treat rocuronium anaphylaxis?
Yes, the million-dollar question. Some case reports suggest clinical improvement, the idea being it encapsulates the rock and stops the reaction.
Makes intuitive sense.
It does, but in vitro studies cast some doubt. They suggest the allergenic part of rock might still be exposed even when it's inside the Sugammadex donut.
So the jury's still out.
Officially, yes. But in a life-threatening rock anaphylaxis, many clinicians would probably still give Sugammadex, weighing the potential benefit against the theoretical risks, especially since improvements have been reported.
Okay. What other serious concerns? Cardiotoxicity. Bradycardia comes up.
It does. Bradycardia is one of the more frequently reported serious adverse events. Can range from mild right through to cardiac arrest or asystole in some cases.
Really?
Yep.
Is it more common in certain groups?
Seems to be reported more often in kids and some specific adult populations. Atropine often works, but not always. Some cases are refractory.
Wow. And anything else cardiac related?
Rarely, cases of coronary vasospasm have been reported. Some researchers think it might be linked to hypersensitivity like Cooney syndrome, allergic angina. So need to have acute coronary syndrome on the differential if chest pain occurs shortly after administration.
Okay. What about bleeding? I've heard about effects on coagulation tests.
Right. Sugammadex can transiently prolong PT and APTT, your standard coag times.
By how much?
Up to about 25%, typically lasting for maybe an hour, especially with doses of 4 kilograms or more.
That sounds concerning. Does it actually cause bleeding?
Well, here's the crucial bit. Despite those lab changes, multiple studies have not consistently shown an increase in actual clinical bleeding or need for transfusion.
So maybe just a lab finding. An artifact.
That's one hypothesis, yeah. An in vitro artifact. But the official advice is still caution, especially if the patient is already on anticoagulants, heparin, warfarin, DOACs.
Makes sense. Be aware, monitor closely.
Prudent approach.
Any other specific pulmonary issues linked directly to Sugammadex beyond just residual blockade?
Yeah, there are reports of upper airway obstruction like laryngospasm or bronchospasm happening after Sugammadex. Also negative pressure, pulmonary edema.
Any specific triggers?
There's some suggestion that maybe using it with desflurane might increase the bronchospasm risk, but it's not definitively proven.
Okay. And drug interactions. That capturing effect must interact with other things besides NMDAs.
Absolutely. The big one everyone needs to know about is oral contraceptives.
Ah, right. How does that work?
Sugammadex can bind to progestogen. Basically, it reduces the effectiveness of hormonal contraceptives, both estrogen and progestogen types.
So what's the advice for patients?
Tell them it's like missing a dose. They need to use an additional non-hormonal contraceptive method like condoms for 7 days after getting Sugammadex.
7 days. Okay, that's crucial patient counseling.
Definitely. Needs to be clear.
Any other interactions? Physical incompatibilities?
Yeah, don't mix it in the same line with ondansetron, verapamil, or ranitidine. Physically incompatible.
Okay. And theoretical stuff, displacement reactions.
There's theoretical concern that drugs like toremifene or fusidic acid could bump rocuronium out of the Sugammadex complex, causing recurization. But honestly, this hasn't really panned out clinically.
Not seen in practice.
Not really correlated, no. And an interesting one with magnesium. Mag sulfate itself doesn't stop Sugammadex working, but if you give mag after you've given Sugammadex, that can cause recurization.
Oh, interesting timing effect.
Yeah. These displacement recurization risks seem more likely if there's a lot of excess, unbound Sugammadex floating around. Dose-dependent, probably.
Which brings us neatly to precision in practice, dosing, special populations. What are the key messages here?
Message number 1. Appropriate dosing based on the depth of blockade is paramount. And that means...
Quantitative monitoring.
Absolutely. Quantitative neuromuscular monitoring using an EMG or acceleromiograph to get that TOF ratio is really considered best practice now. It's the only way to be sure you've achieved full reversal and avoid underdosing.
Avoid residual NMB, avoid prolonged recovery.
Exactly.
How about dosing in obese patients? Ideal body weight, actual body weight.
That debate went on for a while, but the consensus now is definitely dose based on actual body weight,
Okay.
ABW.
Why is that?
Dosing based just on ideal body weight might not be enough for full reversal in morbidly obese patients. You risk underdosing them.
Okay, ABW it is. What about patients with kidney problems? Giving that renal elimination.
Critical point. Since the complex is cleared by the kidneys, severe renal failure, usually defined as creatinine clearance, less than 30 ml mean is generally considered a contraindication.
What happens if they get it anyway?
Clearance is way down. The complex can hang around the body for up to a week.
Wow. Can dialysis help?
Yes, the complex is dialyzable with high-flex dialysis. But if you absolutely have to use it in someone with severe renal impairment, meticulous postoperative neuromuscular monitoring is essential, absolutely critical.
What are the extremes of age? Kids and the elderly.
Well, initially we didn't have much data for kids, but newer studies show it's effective and generally safe, though, as we mentioned, maybe a higher incidence of bradycardia in pediatrics.
Okay, and older patients, over 75.
Recovery might just be a bit slower, likely due to reduced cardiac output affecting drug distribution and clearance, but the same doses are generally recommended.
Okay. Scenario. You've reversed with Sugammadex, case is ongoing, and oops, you need paralysis again. What do?
Right. So the manufacturer guidelines recommend using an alternative blocker, if possible, suxamethonium or a benzylisaquinolinium like cisatracurium, since Sugammadex doesn't bind them.
Makes sense. But what if you have to use ROC or VEC again?
Then you need to wait. There are specific waiting times and doses. For example, wait 5 minutes before giving a 1.2 millikilogram dose, or wait 4 hours before giving a standard 0.6 milligram ROC or 0.1 millikilogram VEC dose.
And if you redose ROC quickly?
Be prepared for potentially delayed onset and a shorter duration of action for that subsequent dose.
Got it. And the really sensitive areas,
Yeah.
pregnancy and breastfeeding.
Okay. Pregnancy. Very limited human data, generally not recommended for routine use. There's minimal placental transfer, but some animal studies, admittedly at high doses, showed potential skeletal issues in rabbits.
So reserved for specific situations. Maybe RSI and obstetrics.
Possibly, yeah, where the benefit might clearly outweigh the theoretical risk. Breastfeeding, though, looks likely safe. Low infant exposure expected. The LactMed database considers it acceptable.
Okay. Phew, that covers a lot of the clinical stuff. But we have to address the elephant in the room,
The cost.
the economic equation.
Yeah,
Sugammadex is way more expensive than neostigmine glyco.
undeniably. It's a significant cost difference, and that's largely down to patents and the time it takes for generics to come through that rigorous FDA approval process.
Which requires proving equivalence, manufacturing standards, bioavailability, the works.
Exactly. It's a high bar, so generics aren't widely available yet, keeping the brand name cost high.
So how do hospitals and departments justify this higher upfront cost?
Well, there's a growing body of evidence looking at the total cost picture. The argument is that the higher drug costs might be offset by indirect savings and, importantly, better outcomes.
Like what kind of savings?
Things like increased OR efficiency, faster turnover times, because reversal is quicker and more predictable, shorter PPCU stays.
And the outcome benefits?
Fewer costly postoperative complications, especially those PPCs we talked about. Reduced hospital readmission rates, maybe even lower rates of postoperative ileus, though the jury's still a bit mixed on that one based on RCTs versus retrospective studies.
Interesting. Are we seeing usage patterns change now that quantitative monitoring is more common?
Definitely. More quantitative NMT use seems to correlate with increased, but also more precise, Sugammadex use. Often people are using slightly lower average doses because they know when reversal is adequate.
And who tends to get it? Is it targeted?
Yeah, it tends to be used more frequently in patients perceived to be at higher risk for complications, high BMI, higher ASA status, older age, emergency surgery, major abdominal or thoracic cases, or simply when higher initial doses of ROC were used.
Makes sense, targeting the value.
Yeah.
So looking ahead, what's next in the world of reversal agents?
Oh, research is ongoing. People are looking at next-generation agents, like things called calibadians.
Calibadians. What's the idea there?
They might offer even broader reversal capabilities, potentially working on different types of NMBAs, maybe even other drugs entirely. Still early days, but the innovation continues.
Fascinating.
Mm-hmm.
So let's try and wrap this up. Sugammadex. Clearly a powerful, precise, very patient-centric tool for NMB reversal.
Absolutely. Huge benefits, especially reducing that residual NMB risk and improving outcomes.
But we absolutely have to be mindful of the side effects, the interactions, and ensure we're using it appropriately in the right patients at the right dose with the right monitoring.
Couldn't agree more. It's a fantastic tool, but like any powerful tool, you need to know how to use it properly, understand the mechanics, the pros, and the cons.
Which leaves us with a final thought for you, our listener, to ponder. Given these proven clinical upsides, but also the significant cost, how does that ongoing dialogue between safety, economics, and innovation continue to shape anesthesia practice?
And what's your role as a clinician in navigating that, advocating for optimal care, for access, but also for continued learning and understanding as things evolve?
Lots to think about. Thanks for diving deep with us today.